Good morning, everyone, and thank you so much for joining us today. I'm Julie Quirin, Chief Operating Officer and Senior Vice President for St. Luke's Health System, and I'm joined today by my friend and colleague, Tammy Peterman, with the University of Kansas Health System, on behalf of the Kansas City area hospitals. I know I speak for my healthcare colleagues in expressing our deep gratitude for all of you on this call, our local leaders, health department officials, and elected officials for all of your support and hard work throughout this pandemic. I would imagine the past 8 months haven't been anything you expected that you would be dealing with in your careers. Managing lockdowns, implementing mask mandates, those are, it's a far cry from what the essential work that you typically do as civic leaders. Honestly, even though we work in healthcare, it's nothing that we expected either. But we're so grateful for your support and partnership as we work to make our community safer together. We talked a lot earlier in the year about flattening the curve. And I think we all understood what that was about. Keeping the level of COVID cases and incidents in our community low enough that we don't overwhelm our hospitals. And this is critical for the health and safety of our caregivers, to make sure we have space and staff to be able to take care of both COVID patients as well as non-COVID patients, those patients that need us for a variety of different healthcare needs. We did flatten the curve very successfully for a while, but I think we all know, and what is bringing us here today is that curve and that line, frankly, is going in the wrong direction again. So again, thank you for your partnership as we continue to work together now to get this under control in our community. We really appreciate your participation in the conversation today. And now I'll turn it over to Tammy to add some additional opening comments.
Thanks, Julie. It's always good to work with you. And thanks to the healthcare executives and the chief medical officers for working so well together over the last number of months. I'm Tammy Peterman, president of the Kansas City Division of the University of Kansas Health System. When this pandemic started, the healthcare community in Kansas City really came together to collaborate. There were a lot of things we didn't know, but here's one thing we did know. We knew that our community would be better if we worked together. And that's exactly what we did. Today, the chief medical officers from across the city will share with you information about the impact COVID-19 is having on our organizations, what we're doing about that impact and to reduce that impact. And we want to share information with you and make sure that we can get information to you to help you in your decision making. We know in healthcare, there are often not easy answers. And as your partners, we want to make sure that we give you accurate, timely, and usable information. Now I'm going to turn this over to my good friend and colleague, Dr. Steve Stites, the Chief Medical Officer for the University of Kansas Health System, who along with his colleagues will provide today's presentation. Now, first of all, I also want to thank all of you for Zooming in and for participating. This is a really busy time for all of you. We know you have a lot of things going on in your work every single day. We appreciate you. We appreciate what you're doing today. We appreciate the commitment you have for our communities. We thank you once again, and we thank you for being with us today. Steve?
Tammy, thank you very much. And thanks to all of you for tuning in today. Also a special shout out to Lee Norman. Lee Norman is the secretary of the KDHE. He's with us. He was my forerunner here. He was a former chief medical officer here at the University of Kansas Health System. And it's a delight to have you and all of our elected officials here today. So why are we here? Well, because there's a change in the reality our community faces. And our group has worked together as CMOs to try and help us communicate this issue to us. So who are those CMOs? Well, let's talk a little bit about that. Okay, if I can get the technological part of the screen to work, it'll all be good. There we go. The area chief medical officers have been working together for our community now. We started coming together last March. And what happened was last March, when the COVID crisis first hit us, we all realized we were having to take action to try and help our community be ready for that. And what that meant was that we started having conversations with each other. We started having a weekly, sometimes twice weekly, sometimes 3 times a week phone call. And our goal was to share best practices, to learn from each other, and to talk about what was going on in our individual hospitals so that we could plan together. By sharing experiences, we knew we would be stronger in doing so. We also knew that we had to look at a model about our community. Initially, if you remember back then in late March and early April, I mean, that was back when we all tried to huddle around a phone together before we even really understood the full pandemic crisis and how to do all the right infection control. Back then, we started thinking, gosh, these national models are out there and they're showing these wild projections. We didn't know how this is going to affect Kansas City, but we started building models for Kansas City. One of the lucky things we have is a great school of population health here at KU, together with our BI team, with David Wild, our VP of Performance Improvement, who's here in the studio with me today, and working with our other CMOs in our community. We were able to put together a model that informed us of how things were going in Kansas City for our hospitals. And that led to our being very concerned about the amount of PPE we had and our ability to take care of a massive surge of patients who could come in. We closed surgeries, we closed ambulatory practices, we built up the PPE, and we helped make sure we were ready for the crisis because we could engineer our entire workflow. So today, when you come to a clinic appointment, and you come in to be seen in a hospital, how that happens is completely different. In fact, I would say hospitals have never been safer from an infection control standpoint than they are right now today. So that's been a great thing. And we were able to bend that curve here in Kansas City. And then in July, another curve came. But we were working together as CMOs to try and be ready for how that responded. And I got to tell you, you've got a great group of chief medical officers here in Kansas City. And a few of us have been on the phone call right from the initiation. And there's what we call the core 6 of the CMOs. You're going to meet them in just a moment because we have a message. And the message is, because of capacity, we are at a critical juncture between concern and crisis. And unfortunately, that needle is trending more and more toward crisis every day. If you look at the number of COVID-19 cases here in Kansas City, I'm sure you're incredibly familiar with this data. We took this from the kansascity.com, the STARS website, and it's clear. The numbers are on the rise. Our 7-day average is higher now than it has been at any point in the crisis. And there are a rise not only here in the Midwest, not here in Kansas City, but also throughout the Midwest, and especially in the rural areas. And one of our biggest concerns now, and this is different than before, is that there is widespread community transmission. It's not just limited to the contacts you know. As I say, what we've been saying before on our program, COVID, it's everywhere you want to be. So we're nervous about that, and we're nervous about this increasing spread. Another thing we're nervous about is a rising case count. Now, you won't find this data anywhere else. This is unique data to the core 6 hospitals that have been part of our CMO call. Others have been on that, but these folks have been on every call, every time. And that includes Liberty Hospital, North Kansas City Hospital, St. Luke's Health System, KU Health System, Truman, and Advent Shining Mission. All the CMOs have been great partners, but this core 6 has been on every call, and every call we start with, tell us what your number of active patients is today. And you can see that curve. And this was from Monday, November the 4th. And each one of those data points is a call. And what you'll see is that there are 277 active patients on November the 4th. We're going to ask everybody for their active count today. So we'll find out what it is. I don't know what it is right now, but we'll find out. But we know that that curve matches that curve, right? When the number of cases in the city rise, the number of cases of hospitalized patients rise, and that's where we are today at our highest number. And that would have been okay, except the number of beds we have, of staffed beds, is running dangerously low. We figured that out when there was a phone call that came to us a few weeks ago, and someone said, we're not able to transfer patients into Kansas City anymore. What's going on? Because it shows in your dashboard that you have over 2,000 open medical beds and over 300 ICU beds. Oh, I was like, that can't be true. So we got the CMOs on the phone. We said, guys, how many patients can you take? What's your count like? it was rapidly clear. There's a big discrepancy between what was being reported through HHS and what was true with the boots on the ground. And so as CMOs, we wanted to start exploring that discrepancy and understand it better, because bed capacity was becoming a problem far greater than what you as elected officials have been led to believe. And we understand that public policy is directly linked to your understanding of the crisis. So today, we need to hit a reset button, because we got to have a better understanding of where we are in that crisis. I'm going to turn to my friend and colleague, David Wild, who's our VP of Performance Improvement here at KU. One of the persons who's been helpful for developing these models that we've used, and also someone who understands the data as well as anybody I know. David?
Thanks, Dr. Stites. So when we started working as a group collectively with those who are helping to collect data and enter data about capacity, bed capacity began to become a significant concern for all of us. That statement in itself is somewhat alarming, I recognize, and no more so than to those of us presenting to you today. As we dug into what was creating a gap between what was compiled and seen in HHS Protect data and what operationally we were hearing from our colleagues on our phone calls, we learned that there were a lot of nuances that led to a difference between what was being entered in HHS and therefore being made visible via a number of dashboards to elected officials like yourself or public health officials. And some of those are outlined here. The first of which is it does appear that for a period of time, some organizations across the metro were entering a licensed bed number instead of a staffed bed number. And while HHS Protect does ask clearly in a set of definitions for staffed beds to be entered into the system to understand capacity, the definitions for that staff bed number are nowhere on the entry page. And every day, each hospital is expected to submit somewhere around 140 different measures to HHS Protect. So just the complexity of the data entry process and the fact that definitions are not easily available likely led to some degree of an elevated number of available beds being entered into HHS Protect by different facilities. There's also a difference between staffed beds and those licensed beds that may be entered. Staffed beds, actually, as it turns out, as we dug into this story more, seems to be an easy definition, but actually has a lot of nuance in itself. For those on the Missouri side, I understand that there's a requirement to report as part of a certificate of need and licensing process, a regulatory requirement to submit a quarterly number of staffed beds that you budget or plan to support to the state. And some facilities were entering that number because it was a definition that already existed and seemed to make sense. But operationally, the question we're asking across the metropolitan area is how many beds can we actually resource today with all of the equipment and all of the staff, nursing staff, pharmacists, physical therapists, respiratory therapists, and physicians, to name a few. But how many beds can we actually staff to be able to take care of more patients today? And that number, as we'll show you here soon, is pretty significantly different from what we are seeing even this week in HHS Protect. And finally, there are fields in HHS Protect that ask for submission of available staffed adult beds. But all adult beds are not created equal. So some beds are not easily converted into beds that would be able to provide care for medical or surgical patients. Beds like behavioral health beds or labor and delivery beds that we know we need to continue to have available for patients and are not designed or resourced to be easily converted to take care of other sorts of patients. In addition, there are a number of ICU beds and other sorts of beds that may have been included in a total bed number, like NICU beds and PICU beds and nursery beds. And so those numbers, in some cases, had been added to the total number and inflated, not intentionally, but inflated what you all may have been seeing as available capacity. And each of those categories of nuance, specifically around definitions, for example, have led to an operational difference in what's reported and what's available. The next slide shows you a little bit of that data. So here we're looking at data that was collected from the hospitals that are regularly participating in our core CMO calls. It's more than actually just the 6 individual hospitals you'll see represented today throughout the presentation. This is actually 11 hospitals that were able to compile and share actionable daily data about the number of beds that are physically available, meaning they are spaces in a hospital that could be used for caring for patients today if staffing wasn't a concern. A more representative number, we believe, of the capacity, the physical capacity of the region. And then staffed beds, the number of staffed beds that could be staffed and fully resourced with the human resources, the healthcare workers that are necessary to provide care in those physical locations. So this is a snapshot. This is a snapshot of a representative Tuesday from Tuesday, November 3rd, of that data compiled in real time from our hospitals about what things looked like on the day shift, Tuesday, November 3rd. On this day, there were 358 beds across these 11 hospitals in our community that were in use for COVID patients. The bar chart, the graph on the right side of the screen, begins to show the discrepancy that I've been trying to describe. So the first column shows from HHS Protect entered data for the same 11 hospitals, shows that the available acute care bed number, or some people would say floor or ward, right, non-ICU bed number in town was over 3,000 beds. But that includes many of those categories that we talked about: labor and delivery, behavioral health, other adult beds that are not available to be transferred or converted into patient care locations for medical or surgical patients. And 420 or so ICU beds, the red bar in that first column to the left. In using our standard definitions of beds that are physically available and able to provide care for patients today, have all the resources, monitors, beds, oxygen, all the things we need, from these same 11 hospitals, we had a number of 153 beds that were physically not filled on November 3rd. And of those 153 beds that were physically not filled, 76 of them could be staffed. Those are non-ICU beds. The same picture appears when we look at ICU beds. 32 ICU beds across those 11 hospitals were physically available to take care of adult patients that day, but 22 of them could be staffed. So a dramatic difference between 3,000 and 153 are 420 and 32. But this explains the picture created when we look daily at staffed and resource beds that are available to take care of patients. It's the reason hospitals from across our community were calling referral centers and being told that we didn't have a bed or we were full. While there may have been physical beds available in each of those facilities, staffing challenges and a number of other concerns, including availability of ICU beds not for adults, for example, may have been part of the reason we were hearing those stories. The next slide begins to show a little bit about why we are concerned. These are the things we believe are leading to the capacity questions and concerns that you saw on the previous slide. Dr. Stites mentioned widespread community transmission of COVID-19 remains our primary concern. As we mentioned, in our hospital today, we have 54 or 55 acute COVID-19 patients and another 25 or so recovering. So 80 or more patients in our hospital today that would not be here if it weren't for a COVID-19 pandemic. That widespread community transmission that we're talking about is increasing hospitalizations, driving that number up at a time of the year where we regularly approach being full, simply because of the number of patients, whether it be actually from influenza or influenza-like illness or other medical needs, end up in each of our hospitals. There are also concerns that increasing cases and continued needs to transfer patients from rural hospitals without the same capabilities could impact our community, although as you'll see, throughout the presentation. Today, that impact is not significant. We're definitely paying attention to it. There are also questions about increasing staff infections, healthcare workers who are infected and unable to provide care, or those who are quarantined due to this widespread community transmission. We've had our highest number of employees of our own healthcare workers positive and on isolation over the past week. It seems every day a new record, and that is directly related to the infection rate and the spread of COVID-19 in our community. Transmission inside any of our hospitals is a rare event, and definitely a rare event from a patient to an employee, a patient to a healthcare worker, when we are all following the pillars of infection prevention and control and using PPE strategies that we know have worked over hundreds of thousands of patient interactions in our community. And finally, we do have to address the fact that there is a limited number of qualified healthcare workers in the staffing pool in our metropolitan area. Many of them are already working significant numbers of hours, a full-time FTE, picking up extra shifts. And so there isn't a large pool available at this point in time to expand the number of healthcare workers available to help us address staffing concerns as part of a capacity problem.
This is a tough time in the community right now, and it's a big change. That graph, I just want to say to you, use Tuesday, November 3rd, and you have a blue and red graph, really.
Yeah, probably could have chosen different
I'm
colors.
just saying. So we don't have David here for his color schemes, but but when you look at that graph, that number of beds that you go down to that's actually available is stark, right? That's a really big change. And if you're used to looking at the HHS data, you'd say plenty of beds. You look at boots on the ground data, and it's like there's no beds. And that's a concern.
It is. And I think, I was trying to very clearly tell the story that there were a number of reasons. In fact, there are a number of reasons that there are still some discrepancies between what's reported in HHS and what you see here. And that is not because of any ill intent or even bad data. It is simply the combination of a significant burden to report, challenging definitions, confusion among definitions because we use the same terms to mean different things in different places or for different regulatory bodies. And also some lack of operational application, right? This thought that NICU beds cannot be used to take care of ICU adults makes perfect sense to those of us who work in a hospital every day. But it's not represented in the data request that we submit to the federal government. And so those things are really important in understanding the actual picture on the ground.
Yeah, actually, we worked with HHS regarding this, and they're like, gosh, this is great what you guys are doing. Thank you so much, because we don't have all the right data. And yet that's what publicly elected officials are using for making decisions. We're like, we got to get the right data in front of folks. So the CMOs, as I mentioned, have been working together for over 7 months. And we've said there are 6 on this presentation, but there are a lot more than that. Olathe Medical Center, Children's Mercy, the HCA hospitals like Research and Centerpoint, as well as the Prime hospitals, especially the Dr. Cicillo from Providence. I mean, there have been a large group of it, but we had to pick a few who are going to talk. And so we chose the 6 who have been with us on every single call to say, okay, that's the core 6, and we're going to show that data. And we have each of those people, but all your CMOs from all the hospitals have done an amazing job at helping us with this question and continue to help us with this question, because we are building a dashboard to show that you'll be able to see every day as an elected official of the real-time data of what our beds are, as opposed to some ethereal number that's out there in the stratosphere somewhere. And that's really important. That way that'll inform public decision-making.
Yeah, if I put my data hat on, performance improvement, managing what we do and how we perform based on data, one of the first questions that we ask is this data actionable? Does it tell the story that we need to make appropriate decisions? And what we're sharing with you today around actual boots on the ground capacity is actionable data. And there are, I said, a number of reasons why HHS Protect may not be representing that, and it's no one's fault. That's not the point of the conversation.
It's not a fault question at all. This is the reality. And one of my first reality checks is to turn to Larry Botts, who, like myself, is a pulmonary critical care doc, has done an excellent job of taking care of patients for a lot of years, and is a CMO over at Advent Shawnee Mission. Larry, how are things going over there?
Well, thank you, David and Steve. I really appreciate the opportunity to help relay this important message. We're, interestingly enough, today, we are at the highest number of COVID patients that we have had in the hospital since the pandemic began, surpassing our highest number that was had occurred back in July. You know, as been pointed out by all of my predecessors, we're experiencing an increase in COVID cases throughout our region, which is increasing number of hospitalizations. So as those number of cases rise, prevention becomes a much more challenging thing to do. As the number of infections increase, so do the number of contacts, of course, who potentially become exposed and then subsequently become infected. So this is going to become even more difficult as we enter the winter months, and more of our time is spent indoors in those crowded conditions. So,
Larry, do you have a sense of how many beds are staff, or how many are staff versus licensed, or whatever the report may have been today that are available?
Sure. Our total non-ICU beds, physical beds, is 231. Our total staffed non-ICU beds is 179. So that's the difference between those two. Our total ICU beds are 28. Our total staffed ICU beds, however, 21. So that's where we sit, at least this morning.
How many patients do you have today, Larry?
So we have 30 today.
Okay.
Which is, again, that's our highest total, as you know, since we started. So the increase in cases has also affected our workforce, as we mentioned before too. We've had only a couple of exposures within the hospital that have resulted in infection since early in the pandemic. But we're seeing an increasing number of our associates who become infected and need to be quarantined due to high-risk exposure and household contacts. In fact, similar to your experience in October, we've had more associates than any other month since we began who were either positive or quarantined because of high-risk exposure and therefore unable to work. And in the early days of November, that trend has increased, actually, and we are on track to surpass even those numbers in October. So although not all those individuals are frontline patient care workers, some certainly are, and therefore adds to our staffing challenges. So we are actively recruiting, utilizing contract nurses and available, repurposing staff as needed. I'm sure where everyone else is in that regard. At this time, we're able to care for both our COVID and non-COVID patients, but I share everybody's concern that we could get to a point where this is going to be a lot more difficult. And with the holidays coming, it's going to be challenging, but our best chance still of avoiding capacity problems in our hospitals is to vigilantly practice those pillars of infection prevention. So wearing those masks, social distancing, practicing good hand hygiene. And even though it's going to be very difficult during the holidays, trying to avoid those situations in which we have large groups in crowded indoor spaces.
Yeah, and we know it works. Again, as David pointed out, the hottest spots in the country, they're not at a bar and a restaurant. The hottest spot in the country is right here in every hospital where we've cohorted all of our COVID patients together, and we don't have transmission to our staff from the patients. Our staff get sick when they go out in the community, and they're like everybody else in this widespread community transmission. But here in the hospitals, and this is the proof, right? This is the proof that anywhere you go, hospitals are the hottest spot, and we don't spread the disease to our staff. And why is that? Because infection control works. And as we see the rise in our hospitals and the lack of capacity, we have to return to the basic principles. So to help that discussion go a little further, I'm going to turn now to my good friend and colleague over at St. Luke's, Dr. Peter Holt. And Peter has been with us every time and has been a stalwart for us. And Peter, talk to us a little bit about what's going on at St. Luke's. And first, how many do you have today at St. Luke's Health System? And don't forget to unmute, Peter. Hey, Peter, you got to hit the unmute button. There you go.
Hitting it. Can you hear me?
We can hear you.
Okay, great. Thanks, Steve. I'd just like to start off and say that I personally and the St. Luke's Health System as a group is thrilled to be a part of this dynamic, unique collaborative in an effort to bring the best care we can bring not just to our local community, but to the states of Kansas and Missouri as referral centers. Our numbers today, Steve, are at a peak. I hate to have to continue to support what others have said, but as a system, we're at 121 today. We've got 34 in the ICU. So those are the highest numbers we have had. I think as Dr. Stites alluded earlier, one of the precipitating events that has really gotten us to this conversation today was an incident that occurred a couple of weeks ago from one of our rural hospitals trying to transfer a patient in for care. And so we feel very strongly as a local healthcare destination that we want to continue to be strong partners with our rural community and be available to them to provide the care that they need for their patients, particularly at times when they feel they don't have the capability or capacity to manage those patients. So what is before you on this slide is the statewide for Missouri and Kansas view of what COVID exposure is in our rural communities. And you can see that it certainly is affecting a large number of communities, rural and metro, in both Kansas and Missouri. And while this is driving some demand, I think that we all feel that what is being requested from the rural community is really, in truth, a very small portion of what we're being asked to manage here in our city. That we have been able to work closely and in partnership with our rural physicians and our rural community hospitals to help them be able to provide care there locally. And in fact, if you look at the numbers, certainly in our system, and I know that it's true in other systems, that the rural hospitals that we have close affiliations with are managing patients there. They have developed a skill set and a capability to manage most of the patients that they have with COVID, except for the sickest of the sick. So we are not getting a demand from the rural communities that we think is stressing our systems here, that I would support based on the information we have, the concept that's been mentioned already in this meeting, that the spread that we're seeing is a local spread. It is a community-based spread. This is not a demand that is occurring because of requests from our regional and rural partners. So Steve, I think I'll stop at that point.
Thank you, Peter. And Peter, I know you guys are taking steps to St. Luke's to think about what's next. What kind of things are you thinking?
Steve, we're trying to prioritize all of the what we might in the past have considered elective. I might now prefer a term deferrable, but we are trying to look now at staffing in areas where we might be able to defer some procedures or some care, so we can use that staff to try to help manage some of the capacity issues in the hospital. So we're looking both at our inpatient clinics, our outpatient clinics, and some of the procedures that we do to see on a prioritized basis, you know, what we can hold off till tomorrow in an effort to provide the care we need to today. I think one of the things that might be of some value to talk about, and others may want to weigh in on this, is the notion that we had back in March and April when we stopped elective procedures. We very quickly recognized that we were just simply deferring important cancer surgeries and heart surgeries and treatments for patients that would ultimately need those. And in fact, it's certainly possible that the decision at that time to stop doing those things, which I certainly feel like was the right decision to make, may have created some of the demand and capacity issues that we have now. And we've recognized that people continue to need care for non-COVID issues, and canceling or deferring that care is not necessarily in their best interest, nor in the best interest of our community. That the basic premise continues to be mitigating risk and cutting down on the numbers of COVID patients that we're being exposed to at the hospital.
Yeah, I totally agree. I think the struggle we face is that before we could cancel, we could withhold some care from elective procedures and same day surgeries, but that was a PPE question. Now it's not an inpatient capacity question. As we look at inpatient capacity, that's harder because you're deferring things like heart surgery and cancer surgery and things of that nature, in which delay can also cause harm. So at that point, you're starting to ration care. It's a little different than saying, I'm going to stop to do your tummy tuck or something of that nature. Well, let me turn now to Mark Steele at Truman Medical Center, because Mark, I think you've got some good points to be made here about how we don't want to turn into some of these other communities. And as you start, just give me your numbers today. How are things at Truman?
Well, thanks, Steve, and good morning, everyone. Fortunately, currently, we're managing the volumes okay here at Truman. But like many of the other hospitals, we're experiencing a recent uptick in our COVID hospitalizations. This morning, we currently have 30 COVID patients in our 2 hospitals. Our peak previously was 36, but right now we're going in the wrong direction. 6 are currently in the ICU and 2 are on ventilators. This uptick, along with the recent significant increases in new cases, positivity rates, and hospitalizations in the metro, as you highlighted, is certainly cause for concern for us. And so we obviously need to do everything we can to help reduce the current spread that's going on. Having more reliable staff bed capacity data will also help us all to better manage and prepare moving forward. So we've all seen some of the recent national headlines, and we certainly don't want to end up in a situation like El Paso, Utah, or Wisconsin. As you can see from this slide, hospitalizations in El Paso quadrupled over a 3-week period, and their ICU units were all at capacity. Wisconsin had to set up a field hospital to help keep up with their increase in cases, and Utah has the potential to have to invoke a triage system that would favor caring for certain patients over others. And we obviously don't want to get to that point. So Steve, that's kind of where we're at.
Thanks. And I think, one of my good friends is the chief medical officer at UT Southwestern in Dallas. And she was texting me earlier this week saying they're getting patients from El Paso because they were out of beds there. So as we look at the next slide, I'd like to turn now to Jim Stewart over at North Kansas City. Jim, as we know, we've tried to close down things before, but that may not be the best answer today.
Hi, Steve, and thanks for this opportunity. No, I think that, as has been mentioned, that previously when we delayed surgeries, it was largely driven by the need for PPE and their PPE conservation and process issues that have been worked out now. And I don't think that canceling those surgeries is going to be the best solution. I think it's important to note that the postponed procedures were not truly elective procedures. They were just not urgent or emergent at the time. And we saw by delaying many of those procedures, there was potential for adverse outcomes for things like, has been mentioned, cancer surgery, bypass surgery, and other necessary but non-urgent conditions. So we don't think that the delaying surgery will fix the current issue unless we just physically don't have the room to place those patients in the hospital. But I think we need to remember that, as has been said, COVID is one disease, and there are many people out there with other diseases that we need to be able to treat in order to serve the needs in our community. And at North Kansas City Hospital, we also had the problem of having physical beds that we couldn't staff, and we felt like we needed to find a way to open up more beds. So we hired over 80 agency staff and are offering bonus shifts to our current employees who want to work extra shifts to try to meet the need, and we were able to increase our bed capacity by doing that. With the current census numbers, it's challenging, but we feel that we need to fulfill the mission to our community and do whatever we can to stay open and treat all of the diseases that need treatment.
Yeah, Jim, I think that's exactly right. COVID doesn't make other diseases go away. How many patients do you have today?
We have 57 active patients.
57. That's kind of high up there. You're getting up there.
Yeah, it is up there. 12 are in the ICU and 9 are on ventilators.
Okay. Thank you, Jim. So you're hearing the same story from all of our partners, and I want to turn now to Raghu Adega, who's the Chief Medical Officer in Liberty and an infectious disease physician as well, to help bring us home. Raghu?
Hey, can you hear me?
Yes, we can.
Okay.
And remind me how many patients you have today.
Yeah, currently we have, first of all, thank you for having me. Currently we have 25 in isolation active cases and a total of 32 COVID, and then 2 in ICU and 2 on vent. That's our today's numbers. Overall, it's about, anywhere between 25 to 30% of our medical beds are taken by COVID these days.
Indeed. So from your sense, what do you think is going to be the future, and where are your patients coming from, and what's going on in Liberty with that? Because you guys have had a lot of nursing home outbreaks too, I think.
Yeah, it varies from day to day, but in general, about 30 to 40% of our inpatients, COVID inpatients, are from nursing facilities. Yes, we've had quite a few of those, and then another 60%, I would say, comes from the communities. And of those, nearly half of them are from nearby areas, in Clay County, Kansas City, Missouri, and Liberty. And another half comes from up north, from smaller rural communities up north. We are on this I-35 corridor, and we do receive quite a few from up north. But
Yeah.
majority still happens to be from the community spread.
Thank you. So you've heard from all of us today. This Swiss cheese model is just a slide to demonstrate how coronavirus likes to spread and what we can do. The pillars of infection control are right there with us. What you're hearing from all the CMOs is really that that we're all in a high level of concern about our capacity, which is different than we were before, even last April and even last July. And I think that's driven by just increased sickness in the community in general, which is true this time of year, and the highest number of COVID patients. So today's total is 318 for those core 6 hospitals. Remember that just a few days ago, that number was 277, and now it's 318. If we continue to rise at that level, we will run out of beds. And that is the reality we face. And there are only so many levers we have left to pull. One of the levers is clearly is procedures, et cetera. But what you're hearing from us today is that the procedures that we now have to cancel are procedures that are delaying care to patients who need them. That's actually rationing care, right? That's what you're doing. And so that is our next step as health systems if we have to do that. So we're asking for your help in trying to help us with widespread community transmission, which is creating a high level of concern amongst your CMOs here in Kansas City. And we're going to work to make sure that you, as publicly elected leaders, get the right data. We're going to get that dashboard right, so you have the right information in front of you as you go on and making decisions for the public. Well, let's see if there's any questions out there, if I can find the chat room button again, that will help us and to show us what's going on. And Lina, I'm not seeing the chat room option up here to answer any questions, so you'll do it.
Yes, we do have some questions. So the first one from Jason Kennedy: how many beds are currently occupied by COVID patients, and how many beds are taken by patients from elective procedures?
Yeah, so for those core hospitals, we gave you the 318 by COVID. And David, if we know the numbers, we can do the math and do the subtraction. So, and just to say right now at KU, I can tell you that COVID-19 is the leading diagnosis for admission in the hospital. Now, everybody has associated medical conditions, but as a cause, it's not cancer now, it's not heart disease, it's not sepsis, it's COVID. And so that's, just think about that. We've added essentially 10 to 15% of a whole new patient population in just a few months. And hospitals are simply not built for that type of swing.
Yeah, and actually, as we've been talking today, the joys of text messages and real-time communication, the physician leadership, the CMO for the region or market for HCA has actually been able to send not only their positive number of cases today, which was 93, that means that we're at 411 in the city
and
today.
That's without Prime yet.
And that's without Prime. And that's without Olathe today. So definitely an impact. And also for the first time been able to share, it took a while to work through the nuances of their staffing questions and numbers as well. And we're able to share some for the first time, some staffing numbers. And so we do know what that total number of beds looks like, and we'll be able to help incorporate that in a bigger picture over the course of time. As far as what percentage of the overall beds in the city might be,
We can get that number as CMOs. We can derive it
Yeah.
from our total bed count.
the 1991.
While you look at that, let me offer another one. One elected person has asked about the recommendations to public health directors and elected officials to help our community avoid the precipice. You know, I wish I had a magic bullet. I do think, you know, I'm Mr. Rose-colored glasses, by the way. I know today's presentation make you think, he's doggy daughter. The reality is I have some rose-colored glasses. We did get information about monoclonal antibody EUAs, early use authorization, that came to us yesterday for potential distribution. I think I'm going to take that as a good sign, because I do think that therapy may be something that will help us stem this tide, but it's still weeks or even months away. We're just getting ready for it and getting ready about how to use it and distribute it through infusion centers. So that's the good news. But in the meantime, we have to deal with the real news. And the real news is very simple. You can either delay care for patients, which we may well end up having to do, or we can try to make sure we follow every rule of infection control. And we're going to stay in our lane. We're not trying to tell public officials how to do public policy. That's not our job. But we want to give you the information that says the numbers are real. Boots on the ground says there are a lot of concerns. And we're going to have to think about those rules of infection control and what can we do differently to try to limit widespread this disease in our community while still trying to keep businesses and things open. We have to do that. We have to have the economy, just like we have to have an economy here. How do we do that? And the answer is we've got to follow the best practice principles of infection and prevention and control. And when you don't, what you see is what we're going to get. And I don't think there's a nicer way to put it than that.
And to circle back just for a moment to the sort of numbers about what percentage of the total beds then are occupied by COVID. If we take that 318 for the 6 hospitals, or 6 systems, I'm sorry, that we mentioned, the core 6 today, that is just a little more than 14% of all the available beds, not of all of the filled beds, of all the available beds in the city, staffed and available, are currently occupied by COVID patients. So.
Another question was, what number will we have no more capacity at? And that's a little bit fluid because everybody's trying to get more staff. It's not a question of how many beds do we have, it's how many staff we have. And then the next thing is, well, we can try to staff at different ratios. Instead of 4 or 5 to 1 on the floor, maybe we can go to 8 to 1. But you have to recognize that's when things start to go wrong, right? That's when things go wrong. If you look at the data that says, why was the initial mortality rate in hospitals 25 to 40%? Why was that in New York and Italy? Now, partly they didn't have the same therapies we have, but the overwhelming, most important variable is that they had not enough people to take care of the sick folks. And when you don't have enough, then things start to fall through the cracks, and little things make a huge difference in health and disease. And when you're in a hospital and you don't have enough staff, the bad things happen. And so I don't think that's not a great answer.
Steve?
Please, Jim.
Yeah, people are often asking about differences between COVID and the flu, and there's a lot of differences. But one thing that's specific to the whole capacity question is that, you know, flu patients come in the hospital for a week, maybe 10 days. COVID patients come in and say 20 days, 30 days, 40 days. We can't get them well and get them out of the hospital, and they're taking up beds for a lot longer than any flu patient ever did.
Yeah, and the most number of flu patients we've had, I mean, we're so much higher than the flu. We've never come close to having 60 flu patients, and actually our number, we have 55 acutes. You didn't hear us ask how many recovering patients, because that's actually for us another 30 beds or thereabouts. So that's over 80 beds right now. Over 10% of our capacity is occupied, of our staff capacity is occupied by COVID patients, and that's a really big number. There's another question about whether or not we're going to be bringing back positive employees earlier, and we already are. The CDC has made some recommendations around that. I think we've kind of pushed that to its limit, David.
Yeah, I think others may chime in, but right now we bring positive employees back at the end of their 10-day isolation period. And that I really don't think has any more room to be shortened. We know from viral replication studies, from viral loads measuring how long people can be infectious after testing positive, that 10 days has been very clearly described as having that potential. So that part, I don't think there's a whole lot of room to move. On the quarantine side, I think almost everyone on the call has some degree of modified work quarantine. So if you are asymptomatic and wearing a mask and we're a relatively low risk exposure, for example, many of those healthcare workers are still providing patient care and working, even though a public health officer may have quarantined them. And that, I think, is the big step that, Steve, that you're hinting at. We've already changed how we manage those that are exposed, and are really managing those that are healthcare workers that are positive to the best of our ability at this point.
Larry, over at Advent Shawnee Mission, I know you guys, we've talked about this before, about the quarantining and how you're dealing with staff. How are things going there around these rules about quarantine?
Yeah, we're following about the same as David said you guys were doing. It's a matter of looking at each individual case, particularly in the exposures, as to how high a risk they were from their exposure, whether they're symptomatic, and then the critical nature of their job. So we're bringing people back that are at low risk exposures. They're still wearing all their PPE that they're supposed to. They're protecting others. And then obviously, if they develop any symptoms, they let us know, and we immediately have them at home. So following the same guidelines, it's a tough, it's becoming more and more difficult, as outlined by all of us, that we've had a lot more staff that are getting exposed and or infected. So.
Raghu, up in Liberty, I know you guys have also had, as we said, the nursing home concerns, as we all have had, but staffing issues. How are things being treated there?
Okay, can you hear me now?
Yes, we can.
Yeah. Okay, great. Well, staffing is always a concern, just like anywhere else. I mean, we're being creative and finding flexible ways to get staffing here, but we all are fighting for the same pool, and there is a limit how much you can do, and the staff can get tired and stressed. So that's the issue that we are struggling with. And as you mentioned, it's we are teetering between the concern and the crisis, and that's where we are, and we don't want to get into the crisis. And as Peter mentioned about the deferrable cases, the issue is, I mean, we are in the community, and we want to provide our patients the right care at the right time. And that's what is going to be affected when we push it into the crisis mode. And that's what we are trying to prevent. And, that's why we are having this conversation with, I've been so thankful for all of us to be able to, exchange ideas and talk about it. And now to involve more and more elected officials and, community leaders to help us and reduce the number of, patients coming in. That's the burden that's pushing us. So hopefully something will come out of this.
Steve, this is Peter.
Yes,
Can you hear
Peter,
me?
please. You bet.
Yeah, I just wanted to add, and I think it's worth emphasizing, obviously we're trying to keep people working, and frankly, our staff wants to keep working. They're not interested in staying at home on quarantine, but I think it's worth really emphasizing for this group, and you alluded to it earlier, and that is that the hospitals are a safe place to be. Our staff is not getting exposed at the hospital. This is community exposure. We're not seeing hospital-based spread of this. We're seeing our staff going home and getting community-based spread of this. And I think, again, that's important to emphasize for the elected officials to appreciate. That's where our staff is being affected.
Yeah, I think, Peter, that's a great point, and thank you for making that. And Mark, one thing I know is that early on, testing was such a concern. Truman's done a great job with pop-up testing and things of that nature, but I don't think testing is, I think we have excess capacity in testing now, and so I'm not sure that that's as big of a concern now. What do you think?
Yeah, no, I think that's right. With the possible exception of asymptomatic testing and how much of that we're doing here locally, it seems like that might be something that we could be doing more of. I do have a couple comments though about the staffing issue, and you sort of alluded to an option of potentially changing staffing ratios and increasing the number of patients that the staff take. But I think, as we all know, that currently we have a lot of staff who are working a lot of overtime, and people talk about COVID fatigue and even COVID burnout. And I think when we measure those kind of things, we're seeing some of that. So I think we have to keep in mind that the staff they're very, very committed, but they're working overtime and really hard. And at some point, you can't do that. So just
I
to
think that's
highlight
right.
that.
We call it COVID weariness syndrome, or COWS, and I think there's a heavy dose of that here in our area and in our community. Well, I know we're over time right now, and I think it's probably time to go, but I just wanted to say thank you to all the elected officials who have participated in this. We hope this has been helpful, and we will work with you, we covenant with you that we are going to deliver on real-time data that is actionable and true from a boots on the ground standpoint, something that I don't really know that you've had all along. So we'll make sure you get that, and we'll try and work with you whatever we can, however we can, on solutions to help keep us out of crisis mode and help us from being overwhelmed. But please hear our message. We're not far away from that, and we're going to need your help. We're not alarmists. CMOs tend to have, we hear a lot of things every day, and we all have to cope with all sorts of things being thrown at us. But the simple reality is that this is unlike anything we've seen before. And we know that the rules of infection prevention control work. We can try to throttle back on some care, but when we do that, we're rationing or redistributing care. And what we really need to do is try to redistribute community widespread transmission in a negative way. I want to say thank you to all the CMOs who are on this call with us and all the CMOs who have worked with us across our region. It has been a brilliant collaborative effort. Sometimes it's strange bedfellows. You see us all working together. Maybe pandemics have a silver lining, but this is a great group of people. And I can't tell you how much it has meant to be able to have each other to talk to and depend on. So with that, we'll close today's meeting. Good luck. And please let us know if there's anything more that we can do to help you as we try to manage COVID-19.